I just knocked on the door, closed the door for privacy for the patient, performing hand hygiene, confirming patient, I'm reading, making sure it's the right patient, and date of birth. Did that, checked it again. Same person, it's Mr. Ted. Also, if somebody's in the room with Mr. Ted, we're going to do our HIPAA procedure. Meaning, if the person, we're not going to give any information that's pertinent to Mr. Ted to someone else if Mr. Ted does not agree. He agreed, so the person could stay, but if the person, he said no, I'd have to ask the person to leave and wait till the procedure was over. That being said, the equipment we're going to use today is a pen light, tongue blade, cotton swab, cotton ball, tuning fork, about 128 to 250 hertz, precision hammer or leaf flex hammer, blood pressure cup, pulse ox, watch, and thermometer. Now, what we're going to do also is we're going to take the vitals. We would take a blood pressure, we would take temperature, heart rate, respiration, pulse ox, and pulse. Before we would start, I would explain to the patient what we're going to do today. We're going to do a neurological exam, Mr. Ted. So we're doing a neurological exam. Now, part of the exam is I would ask him a series of questions like, has he had any headaches, frequent or severe? Has he had any head or concussions, head injuries or concussions? Has he been feeling dizzy, lightheaded, or has he had vertigo where things are spinning around? Has he had any seizures, tremors, weakness or incoordination, like he can't he can't walk right? Has he felt any numbness or tingling in his extremities? Has he had any difficulty swallowing? Has he had any difficulty speaking? Has he had any in his past, any significant neurological issues such as a stroke, spinal cord injury, meningitis or encephalitis, congenital defects, or has he had alcoholism? After I've gone through those series of questions, then I would do a mental status. Mental status is something you're constantly doing. As soon as you walk in the room, just like an inspection, you're doing the mental status of the person, how they're standing, walking. So I'm looking for consciousness. So while I'm speaking to him, asking these questions, I'm looking to see if he's aware of me, of his own existence, his feelings. I will look at his language. Is his language appropriate? Also, I look at his communication. Also, I look for his mood and affect, meaning mood for long-term and effect for temporary. I will look for his orientation to the world and to itself while I'm asking these questions. I ask him a memory question. So what I would do is at the beginning of the conversation, I want you to remember these 3 words, or I'll say 2 colors. And then once we finish a couple minutes later, I would ask him those questions. Do you remember what I asked you? That's testing his memory, short-term and long-term. I would see if he's see if he can think abstract, thought process, thought content, and perception. All of that can be done when you're walking in, and it's constantly being redone. Inspection never stops. You're always inspecting the patient the whole time as soon as you walk into the room. Next, I would do, after I did my questioning, I would work on his nerves. The first nerve I would work with would be his olfactory nerves. So when I have something like a spice or something, or a perfume, I put it under his nose, and I would ask him, what do you smell? It doesn't have to be anything strong. He would tell me what he would smell. So if it was a spice, he would say it was a spice, or if it's a perfume, as long as it's not too highly scented, he would tell me what he smells. Next thing I would do a Snell chart. So Mr. Ted, I'll have it about 20 feet away. I tell him to cover one eye, look at the chart, and then I tell him to cover his other eye. So Ted would cover one eye, read the chart, then he would cover his other eye, do the same thing. Also, I do a visual field test where I put my finger outside and I ask Mr. Ted, as soon as you see my finger, make sure I do both sides. Next thing I would do is I would do a diagnostic position test, where I would do like this, do both sides, and I always make sure I try to do both sides to see how, so I would do both sides to see his symmetry, see how his eyes and muscles are moving. And doing that test, that'll also cover that the second. So I did the cranial nerve for his nose. I did the optic nerve test, and I also did the cranial nerves 3, 4, and 6, which is oculomotor, trochlear, and abductive nerves, or extraocular muscles, to make sure they're intact. The pupils are equal, round, reactive to light, perla, no ptosis. That's what I'm checking for. The next thing I would do is his cranial nerve or trigeminal nerve. So I would tell him to clench his teeth, and then I would put my hands here and see how he tries to move it. If there's no movement and his teeth stay clenched, he's good to go. Make sure it's intact. I'm palpating. I make sure I have my fingers over there. Intact, and it's equally badly, meaning it's not clenched here and you can feel the looseness here. It's both tight. It's tight. So, next thing I would do is, if I had a cotton ball, I would put the cotton ball on his ophthalmic, maxillary, and mandible. I do the same on this side, ophthalmic, maxillary, and his mandible. Make sure I do it on both sides. I'm looking for meaning they're both equal. There's no difference on both sides. Next, I would do his facial nerve. So I tell him to smile, frown. Then I tell him to close his eyes tight. So he would close his eyes tight, and I try to open them. If I can't get them to open, they're good to go. I tell him to lift his eyebrows. He don't have no eyebrows, so he's good at my eyebrows. Okay? And then I tell him to show his teeth and puff his cheeks. If he can do all of that, then he's good to go. The next one I would do is cranial nerve 8, acoustic. So what I would do is I go up to his ear and I would whisper. And I would tell him before I start, repeat to what I said. You repeat it up, he's good to go. His acoustic is good. The next nerve, which would be nerve 9 and 10, which would be glossopharyngeal and vagus. So I tell him to stick out his tongue, and I would get a blade and put it on the tongue and check for any movement. While I'm doing that, I ask him to say, ah, and then I see if there's any movement of his tonsillars. Make sure everything's equal, it's looking good. That done. The next one is nerve 11, cranial nerve 11, spinal accessory. So, spinal accessory means I would tell him to turn his head, and I put resistance behind it. Then I turn his head, and I put resistance behind that. Then I tell him to shrug his shoulders, and while I press down. If I feel that there's both equal, it's about the same, he's good to go on that as well. Next nerve I would do would be the hypoglossic, where I tell him to stick his tongue out and say light, tight, dynamite while I got the tongue in there. I should be able to hear him say that even with the tongue depression loud and clear. Very distinctly. Now after I've done that, I want to ask him, once I've done all of that, I'll make sure he's clothed. Well, Ted is never clothed. He's always naked. That's just Ted. So Ted, stand up. And I ask Ted to walk straight. Boop, boop, boop. Then I ask Ted to walk tiptoe on his tiptoes. Then I ask Ted to walk on his heels. What I'm looking for is making sure his gait is smooth, is coordinated, he's not tripping over himself. Boom. And when I ask him to walk, I ask him so he would walk this way, then he would walk back to me. He would walk tiptoe, and he would walk heels back to me as well. So I get to see forward and backwards. I'd ask him to walk maybe 10 to 20 feet, but really don't need to see that much. You can pretty much see a gait after about a couple of feet, but hey, whatever works for you, that's what you do. Okay, the Romberg test, that's for his balance. This time I have Ted to close his eyes, stand up straight, and I make sure I stand there with him just in case he might waver and fall. I do that for about 20 seconds. Then I tell him to uncover his eyes, and we're good to go. If he didn't look like he was shaking too bad, then that test is good to go too. Now that we've done the motor test, next we do the sensory, where I would get something. Okay, I wouldn't necessarily use a pencil, I'd probably use a tongue depressor or something, and I would do his arms. At various points, I tell him to close his eyes, and I take the soft part, then the pointy part, at various points on his arms, and I do the same for his legs. I wouldn't let him know where I'm doing it, and I also make sure he's covering his eyes the whole time. That's to see his sensory, make sure everything's up to par. Next thing I would do, think of this as a tuning fork. I would I take the tuning fork, and I put the tuning fork on one of his fingers. Also, I'd tell him to close his eyes too, just so he's not giving any reaction. I tell him when does he stop feeling the tuning fork. I would do this on both arms. Also, I would do it on his foot. I would do the tuning fork on his foot, about his great toe. Okay, reflexes. While holding his arm, so I would hold his arm about here. I would take my hammer, and it'd be a reflex hammer, not a regular hammer, a reflex hammer with a rubber end on it. Hit my finger where I'm holding it, and sense the reflex. Reflex should be about a +2. Anything more than that, there's something going on. Anything less than that, there's something going on as well. Okay, so I already did the reflex with his arm this way. Next, I'll have his arm hanging like this. I would hit the reflex hammer and look for a reflex. I also tell him to hang his arm limp. He doesn't have a stress, so I'll try to get him not to be stressed. I tell him to be relaxed and relax his arm, and boom, I would hit it with the reflex hammer. Okay, the knee. Just below the patella is your tendon. I tell him to relax his knee, make it limp, and it should be, if it's done right, it should be boom, you hit it just like you see on the TV shows, boom. It's not a big kick. It should be boom, it's kick. You can see it once it's done. Achilles. What I would do is have him rotate his leg out, put it on my knee, support it, and I would hit his Achilles tendon back here with the rubber hammer, looking for the reflex. That's the Achilles. Now, some other things, if this was a baby, some reflexes you can look for. You would have the tunic reflex for the spine. Oh, I'm sorry, not tunic. You would look for the rooting reflex, where you touch the baby's cheek, they'll turn to you because that's where they like to suckle. You do the palmar reflex, where you put your finger in the baby's palm. As soon as you put that finger in there, they're going to grasp it. That's checking for the palmar reflex. Babinski reflex, where I stroke it against their foot. You should see a reflex. Motor reflex, where if the baby's laying down, you turn their head, I think they pop into a fencing move. Now, I think we just did all the reflexes. So to recap, we did the bicep reflex, the tricep reflex, the patellar reflex, the Achilles reflex. Next, after we've done all of that, I would wash my hands, document, and what I'm documenting is I'll be documenting no unusual, frequent, or severe headaches, No head injuries, dizziness, or vertigo. No seizures or tremors. No weakness or numbness or tingling. No difficulty swallowing or speaking. No past history of strokes, spinal cord injuries, meningitis, or alcohol disorder. That being said, this is where I could implement my Glasgow Coma scale, especially for EMT. They use it all the time when I'm looking for a level of consciousness. What I'm using is eye-opening responses, motor responses, and verbal. Everything we just discussed, I'll be using all of those based on a number scale. So based upon that eye-opening, and I'm asking them questions, based upon their motor responses, and I'm looking at that, and based upon their verbal responses while I'm asking them questions. Now, if the score is 7 or less, there's a coma, or a possibility of a coma. 15 is usually normal. Now, the next thing I would do is, while I'm documenting, I would document mental status. TED appears to me to be appearance, and I look for appearance, behavior, speech appropriate, alert, oriented to person, place, and time, and recent and remote memory. Meaning, if I ask them a question and 5 minutes later they repeat it back to me, I could tell whether they have a recent or remote memory. Also, with their nerves, I would say olfactory nerve is intact. Remember the spice I put under the nerve of their nose? That would be it. I would say vision 20/20, left and right. I would say peripheral fields intact by confirmation. And by the way, I skipped that, but I'll bring it up now. I'll use a pen light to do that. I would use cranial nerves 3, 4, and 6 intact. No ptosis, perla. Pupils are equal, round, react to light, and accommodation. Cranial nerve 5, sensations intact, equal bilaterally, draw strength is equal bilaterally. Cranial nerve 7, facial muscles intact and symmetric, always symmetric because you're always comparing one side to the other. Hearing, remember I whispered in the ear, I would say words heard bilaterally, meaning I whispered in one ear, I did the same thing to the other, bilaterally. Cranial nerve 9 and 10, swallowing intact, uvula raised in midline on phonation. Shoulder shrug, which is cranial nerve 11, and head movement intact and equal bilaterally. Cranial nerve 11, protrudes midline to tremors. Motor, no atrophy, I saw no weakness, I saw no tremors. His gait was smooth and coordinated and able to tandemly walk. Negative Romberg test. Once again, the Romberg test where I told him to close his eyes and stand. See if he swayed. That's the Romberg test. Sensory, sharp and dull sensations. He felt both, he responded. Light touch and vibration intact. DTRs, deep tendon reflexes, 2+. That's where I hit the hammer on his knee, on his arm, on the back of that. That's deep tendon reflexes. So once I get to that, I'll make an assessment, and overall assessment would be neurological system intact, healthy functions. At this time, after I finish my documentation, I would turn to the patient. I would say, do you have any questions? Any concerns? This is the time you would ask, and sometimes you can even ask it over the course of the examination because people do have questions, and that's the best time to teach. After that being said, then I would do my health promotion. I would say, know about strokes, know the signs. Fast, I tell them little mnemonic fast, where F stands for face drooping, arm, A stands for arm weakness, S is speech difficulty, and T is time to call the 911. Once again, fast. Face drooping, where one side of my face is not quite looking like the other side, there's a problem. You don't even have to remember all of that. You see somebody on the street and it look like half their face is drooping, do something, say something. Somebody's got a problem. I don't know if it's a stroke or not. You don't have to be the medical doctor on the scene. Do something. So, face drooping, arm weakness, speech difficulty, covfefe, whatever, time to call. That being said, thank you.